Student from Institute of Vascular Surgery in NMC, Chennai. I'll be talking about the topic vasculitis and other uncommon arteriopathies. But to start with, the vasculitis includes a group of inflammatory disorders characterized by inflammation and necrosis of blood vessels, which subsequently leads to ischemia and infarction of the organs supplied by the blood vessels. And this includes a heterogeneous group of disorders, so they have variable presentation. Depending on the size of the vessels involved, we have a similar group of symptoms for each group of vessels involved. For large vessel vasculitis, patients usually present with limb claudication. We can also find vascular fluids or asymmetric pressures or even absence of pulses. In medium vessel vasculitis, we can find symptoms like cutaneous nodules and ulcers. This is in involvement of cutaneous subdermal vessels, presence of livedo reticularis, or even digital gangrene when digital vessels are affected. When epidural vessels are affected, we can form symptoms like mononeuritis multiplex. And when renal vessels are involved, we can find renovascular hypertension. In small vessel vasculitis, when small epidermal vessels are involved, we can find symptoms like palpable purpura, urticarial skin rashes. When pulmonary and renal capillaries are involved, we can find glomerulonephrititis and alveolar hemorrhage. When the capillary beds in eye is involved, we can find uveitis and scleritis. Coming to histological characteristics, commonly we find infiltration by neutrophils and mononuclear cells with or without giant cells. There may be pan-mural destruction of the vessel wall and evidence of leukocytoclasis, that is, disruption of leukocytes may be seen in some of the conditions. In some of the conditions, the structure of the vessel wall is well maintained. For example, in TAO, in other conditions, the structure of the vessel wall itself may be altered. We can see cell-mediated inflammation in diseases such as giant cell arteritis, Takayasu arteritis, and primary CNS vasculitis. Whereas the inflammation is immune-mediated, that is in case of polyarteritis nodosa, henoxarin purpura, cryoglobulic vasculitis, and cutaneous leukocytoplastic angiitis. In ANCA-associated vasculitis, it involves both cellular and humoral immune responses. Coming to imaging, there is a definite role for angiography in making a diagnosis in case of large vessel and medium vessel vasculitis. In large vessel vasculitis, we can see stenosis or even aneurysm formation. Whereas in medium vessel vasculitis, we classically see irregular asymmetrical tapering and narrowing. We can also see beaded appearance, that is segmental stenosis with aneurysm formation. Arteriography is of not much use in small vessel vasculitis. Duplex has a role in diagnosis and management of giant cell arteritis. Whereas MRI with gadolinium contrast is more specific for visualizing larger arteries, especially aorta, subclavian, and carotid arteries as such. The contrast enhancement might be more specific in case of active arteritis. Here we can see enhancement of the vessel wall itself. And recently we've started using PET scan also. Recent guidelines suggest use of PET scan for early diagnosis and even prognostication for identifying active vasculitis in a few of the patients. But most commonly, it has been used in an experimental setting only. Coming to the classification of vasculitis, the first international Chapel Hill consensus was held in 1994. And this gave basic definitions and diagnostic criteria for most commonly occurring vasculitis. It was revised again in 2012. And this is the latest classification after 2012 conference. So the first class, we have large vessel vasculitis. We have giant cell arteritis and Takayasu arteritis under large vessel vasculitis. And the second class, we have medium vessel vasculitis, that is polyarteritis nodosa and Kawasaki disease. And the third classification is small vessel vasculitis. So we have subdivided this into immune complex mediated, also called as non-ANCA vasculitis, and the other class is ANCA-mediated vasculitis. So in immune complex mediated, we have commonly occurring vasculitis such as anti-GBM disease, cryoglobulinemic vasculitis, IgA vasculitis, and anti-complement C1 vasculitis, also called as hypocomplementemic urticarial vasculitis. Whereas in ANCA-associated vasculitis, we have microscopic polyangiitis, and we have granulomatosis with polyangiitis, previously known as Wegener's granulomatosis. And we have eosinophilic granulomatosis with polyangiitis, previously known as Chopra's syndrome. So the fourth classification is variable vessel vasculitis. So this vasculitis can affect small, medium, and large vessels. So we have Behçet's disease, Cogan syndrome, and thromboangiitis obliterans under this heading. Thromboangiitis obliterans, it is interesting to note that it was originally not classified in the Chapelian conferences, but this best fits into this group of disorders. Later, we have single organ vasculitis, that is cutaneous leukocytoclastic vasculitis, that is skin involvement, cutaneous arteritis, primary CNS vasculitis, isolated aortitis, and others. We have vasculitis associated with systemic diseases that is seen in lupus, rheumatoid vasculitis, and also sarcoid vasculitis. We have vasculitis secondary to other etiology, infections like hepatitis C, B, hepatitis B, syphilis. It might be drug-induced. It is also called hypersensitivity vasculitis, maybe cancer-associated vasculitis, among others. So this is another picture just showing the same classification. Large vessel, we have Takayasu arteritis and giant cell arteritis. Medium vessel vasculitis, we have polyarteritis nodosa and Kawasaki disease. Whereas immune complex, small vessel vasculitis, they can involve small arterioles, the capillary membrane and the capillaries, and the venules also. ANCA-associated small vessel vasculitis can affect medium vessel also, along with arterioles and the venules, and even slightly bigger veins also. Coming to large vessel vasculitis, we have two primary disorders, that is Takayasu arteritis and giant cell arteritis. There are other ill-defined conditions which affect aorta. For the sake of making an easy discussion, I'll discuss these also with the same group. Takayasu arteritis, it's a different topic by itself, so I believe it is going to be discussed in the coming classes, so I'm not discussing much about it. I'll start with the giant cell arteritis. This is also known by other names. It is previously called temporal arteritis, arteritis cranialis, Horten's disease, granulomatoous arteritis, and arteritis of the age. This is a systemic inflammatory vasculitis of unknown etiology. And even though it is classified as a large vessel vasculitis, it also involves medium and small arteries. It is particularly involves superficial temporal artery. It can also involve ophthalmic, occipital, vertebral, posterior ciliary, and proximal vertebral arteries. It primarily involves patients over 50 years of age, and it is more common in Caucasian patients. There is more propensity for female presentation of this disease, and smoking in females increases the risk of developing the disease by 6-fold. Coming to the etiology, exact etiology remains unknown. It is associated with the HLA-D4 haplotype. Infectious agents like chlamydia, mycoplasma, parvovirus, varicella zoster have been suspected as the impedance which starts off this destructive inflammation. Coming to pathophysiology, first in the normal arteries, in the adventitia media junction, we have dendritic cells. These act as sentinels. And in presence of HLA-D4 haplotype, when there is a contact with this unknown instigator, these dendritic cells become activated, and they recruit CD4 cells, which are in the media. These CD4 cells propagate along two lines. When they differentiate along Th17 lineage, they cause systemic manifestations. And when they differentiate along Th1 lineage, through interferon gamma, they cause activation of macrophages, and the macrophages are converted into giant cells. And giant cells bring about this localized inflammation in the vessel wall by release of matrix metalloproteinases and reactive oxygen species, along with release of growth factors. So this leads to intimate hyperplasia and other changes. We can prominently see that there is formation of neointima with reduction in the lumen of the vessel wall, which often leads to thrombosis. And we can also see degraded internal elastic lamina. And in the media, we can see proliferation of smooth muscle cells, along with accumulation of giant cells and activated CD4 cells. In the media, we can see medial laminar necrosis, and the adventitia is flushed with activated dendritic cells and CD4 cells. Coming to clinical features, there are constitutional manifestations like anorexia, fever, malaise, myalgia, night sweats, and weight loss. And commonly reported symptoms include headache, polymyalgia rheumatica, and fatigue and malaise in 56% of patients. Jaw claudication seems to be a more specific symptoms. This is due to involvement of arteries supplying the muscles of mastication, and fever is seen in 35% of the patients. Ophthalmological symptoms is seen in 50% of the patients. It can be unilateral blurring of vision or a painless loss of vision. Occasionally, it might be diplopia also. It might even present as a partial field defect, which later progresses to complete blindness. So the physical findings include scalp tenderness and the reduced pulse and tenderness in temporal artery. There might be discrepancies of blood pressure in the upper extremities. We might even note a carotid or subclavian buoy in these patients. Coming to the criteria for diagnosis, this is the American College of Rheumatology criteria. They have described 5 criteria, and at least 3 out of these criteria should be present to make a diagnosis of congenital arteritis. The first criteria is age at onset, which is more than 50 years. The second criteria is new onset headache. The third criteria is temporal artery abnormality, that is presence of tenderness or decreased pulsation. This is important. This should be present in the absence of any evidence of atherosclerosis of other cervical arteries. And the fourth factor is elevated ESR. The fifth factor is abnormal artery biopsy. The biopsy should show mononuclear cell infiltration or a granulomatous infiltration with multinucleated giant cells. The biopsy is usually taken under local anesthesia, and at least 1.5 to 2 centimeter of the artery should be taken for biopsy. Coming to medical treatment, corticosteroid therapy is the cornerstone, and oral prednisolone is given. In patients with visual loss, intravenous lethal prednisolone will be given. Low dose aspirin is also given. Newer agents like tocilizumab, that is anti-interleukin 6 antibody, tumor necrosis factor inhibitors like fleximab and etanercept, immunosuppressive agents cyclophosphamide, azathioprine, methotrexate, and Dapsone all have been used in the medical management. Coming to the role of surgical revascularization, it is required in very few patients because robust collaterals usually develop in case of arterial stenosis. They described the use of Pallin angioplasty under the cover of immunosuppressants. And when there is abdominal aortic aneurysm, is noted, it has to be repaired according to standard guidelines for management of abdominal aortic aneurysm. Coming to other conditions which affect aorta, we have idiopathic aortitis. This is inflammation of aorta, which is discovered incidentally on histology, seen in around 8 to 10% of patients who are undergoing surgical aortic aneurysm repair. This may be due to conditions like idiopathic retroperitoneal fibrosis, popularly called as Ormond's disease. This is characterized by development of extensive fibrosis throughout the retroperitoneum. This is suspected to be an immunological response to antigens such as insoluble lipids, which are present in atherosclerotic plaque. And when there is thinning or breaching of the media, this insoluble lipids, they leak into the retroperitoneum and stimulate an immunological reaction. and this causes the fibrosis. Classically, on CT, we note that there's a homogeneous mass around the aorta, which leads up to the aortic bifurcation. And there is associated medial deviation of mid part of ureter and secondary hydronephrosis. Treatment includes glucocorticosteroids and immunosuppressive agents. Estrogen receptor antagonists are also used. Rituximab, that is monoclonal antibody against the CD20 cells, that is also being used for this. Surgical ureterolysis may be needed in patients with persistent hydroureteronephrosis. The other condition causing aortitis is IgG-related systemic disease. This is seen in older males who have a history of allergic diseases and atopy. And several organs may be involved. That is, autoimmune pancreatitis may be seen, cholangitis may be seen, salivary gland involvement and scleroderma silidinitis may be seen. And this is associated with chronic lymphoplasmacytic aortitis and aneurysm formation. Treatment includes steroids, TM, ARDS, and rituximab. Third such condition is ERDHEIM-CHESTER disease. This is due to defecting functioning of histiocytes, and this is associated with the periaortic fibrosis referred to as spotted aorta, and there is periarterial inflammation of coronary arteries, and there is even pericardial thickening and pericardial effusion. The other feature is presence of inflammation around the kidney, noted as fat standing, or it looks as a hairy kidney on CT scan. This is due to proto-oncogene BRF mutations. So BRF inhibitors like dabrafenib and ectorafenib, as we have been used in the management of this disease. Coming to medium-sized vasculitis, we have polyarteritis nodosa and Kawasaki disease. Coming to polyarteritis nodosa, this is necrotizing vasculitis of small and medium size arteries, and it is characterized by absence of glomerulonephritis and absence of ANCA antibodies. So necrotizing lesions results in microaneurysm formation, and aneurysm ruptures can lead to hemorrhage, and it can also lead to thrombosis and consequent organ ischemia and infarction. Coming to the etiology, it may be idiopathic, where we cannot identify a etiological agent, or it can be due to secondary to hepatitis B infection. So PAN may be secondary to hepatitis B infection in 8 to 30% of the patients. In the idiopathic PAN, it is associated with recessive mutation in CECR1 gene. This leads to unregulated proliferation of activated T cells and also unregulated differentiation of monocytes into macrophages. HPV-related PAN, there is viral replication which induces the vessel wall, and also there is immune complex-induced disease. All this leads to endothelial dysfunction and various manifestations. We can see there is fibrinoid necrosis of the vessel wall along with infiltration by neutrophils and lymphocytes all along the vessel wall, and there is also thrombosis, the lumen of the artery. Clinical features, we can see constitutional symptoms like fever and weight loss in setting of organ dysfunction. Skin lesions, including palpable purpura, levodoreticularis, necrotic lesions and digital infarcts may be noted. Peripheral neuropathy and mononeuritis multiplex may be noted due to involvement of epineural arteries. And abdominal pain may be seen due to mesenteric vasculitis, and hypertension may be seen due to involvement of renal vessels. Coming to diagnostic criteria, again defined by American College of Rheumatology. They have described 10 criteria, out of which 3 need to be present to make a diagnosis. The first criteria is weight loss of more than 4 kgs since the beginning of illness, and the presence of levodoreticularis, presence of testicular pain or tenderness, presence of myalgia, weakness or leg tenderness, involvement of nerves in terms of mononeuropathy or polyneuropathy, diastolic BP of more than 90, elevated blood urea and creatinine, presence of hepatitis B infection, and angiographic abnormalities, which shows aneurysm or occlusion of visceral arteries, and biopsy of small or medium vessel arteries, which demonstrates infiltration by mononuclear leukocytes or granulocytes. Coming to the treatment, idiopathic, that is non-HBV related polyarteritis nodosa is treated with high-dose steroids, IV cyclophosphamide to induce remission. After this, azathioprine or methotrexate is used for maintaining the remission phase. Hepatitis B related PAN, it is treated with steroids and antiviral drugs such as vidarabine and interferon alpha 2B and lamivudine. In resistant cases, plasmapheresis also has been used. Patient might need appropriate surgery in case of GA manifestations, in case of bowel ischemia, cholecystitis or appendicitis. Microcoil embolization of visceral and cerebral aneurysms may be indicated. If patient presents with limb-threatening ischemia, if suitable target vessels are present, we can consider these patients for bypass procedure when the disease is in a quiescent stage under the cover of immunosuppressants. Coming to the second disease, that is medium vessel vasculitis, we have Kawasaki disease, also called leukocutaneous lymph node syndrome. This usually presents as acute febrile illness in early childhood, and this is characterized by necrotizing vasculitis of median vessel arteries, especially the coronary arteries. And coronary artery aneurysms develop in 25% of untreated cases. The etiology remains unknown. It is suspected that a viral or a waterborne vector or even genetic predisposition might have a role in the etiology. Coming to the diagnostic criteria defined by American Heart Association, it requires fever of at least 5 days duration, along with 4 of the 5 principal clinical features. So the 5 principal clinical features include extremity changes, that is palmar and plantar erythema, and the second one is polymorphous rash. The third one is oropharyngeal changes, that is presence of cheilitis and strawberry tongue. The fourth one is bulbar conjunctival injection, and the fifth one being lymphadenopathy, that is unilateral non-purulent cervical lymphadenopathy. We can also see coronary aneurysms on CT angiogram, and we can also see atypical peripheral aneurysms involving subclavian artery, axillary artery, or even the iliac artery. Coming to the treatment, initial treatment is with high dose aspirin, that is 80 to 100 mg per kg per day in 4 divided doses, and intravenous immunoglobulin administration, that is 2 gram per kg as a single infusion. In resistant cases, we might need to do a plasma exchange. Other drugs like apiximab and infliximab have been used. They've even described the use of lytic agents in presence of coronary artery thrombosis in severe cases. In presence of coronary artery aneurysms, we might need to do a surgical or catheter-directed coronary intervention. And in a very severe form, cardiac transplantation might not be needed. TAO also affects medium and small vessels, especially infrapopliteal and intrabrachial. This also requires a lot of discussion, and I believe subsequently it is going to be discussed, so I'm not discussing much about TAO. So other conditions which can mimic medium vessel vasculitis include pseudoxanthoma elasticum, neurofibromatosis, and vascular type Ehlers-Danlos syndrome. Coming to the small vessel vasculitis, we can classify this as immune complex mediated or non-ANCA vasculitis and as ANCA associated vasculitis. Among the immune complex mediated vasculitis, we have anti-GBM disease, cryoglobulic vasculitis, IgA vasculitis, and anti-C1q vasculitis. Among ANCA-associated vasculitis, we have microscopic polyangiitis. We have granulomatosis with polyangiitis, previously called as Wagner's granulomatosis. And we have eosinophilic granulomatosis with polyangiitis, previously called as Chagas syndrome. So this is a pictorial representation of involvement of cutaneous and subcutaneous vessels. So in case of cutaneous lymphocytoplastic angiitis and the henoch purpura, we can see that the uh, deposition of this immune antibody complex usually occurs in small arterioles and capillary beds, which are present in a dermoepidermal junction. And there is a very rarely involvement of arteries which are more than 100 microns in size. Whereas in ANCA-associated vasculitis and cryoglobulic vasculitis, we can see all sizes of the vessels are involved. And this also includes medium-sized vessels which are present in the subcutaneous layers. Whereas in polyarteritis nodosa and giant cell arteritis, it is only the larger vessels which are involved. So coming to immune complex mediated vasculitis, this is again a heterogeneous group of disorders. They are linked by inefficient or dysregulated clearance of immune complexes. So the most common type include hypersensitivity vasculitis, henoch purpura, and mixed cryoglobulinemia. There are rarer forms of disease also. Connective tissue disorders like SLE, Sjogren's syndrome, or rheumatoid arthritis can also be associated with this form of vasculitis. Direct immunofluorescence of blood vessels shows characteristic types and patterns, like the picture I showed before. And the cutaneous involvement of small blood vessels is the most prominent presentation, but extracutaneous involvement also occurs in some forms. And classical cutaneous findings include the palpable purpura, that is involvement of post-capillary venues, and the involvement of larger vessels can also form pustules, vesicles, urticaria, and even small ulcerations. Coming to hypersensitive vasculitis, this is due to allergic reaction or due to a medication or an infection. This is treated by removal of offending agent and the brief course of steroids. Henoch purpura is associated with presence of purpura, arthritis, glomerulonephritis, and colicky abdominal pain. IgA is predominant in this, treated using glucocorticoids and supportive therapy. Cryoglobulic vasculitis is most often associated with non-standing hepatitis C infection, and it is treated with antiviral therapy and rituximab. And we have anti-GBM antibody disease, previously called as Goodpasture syndrome. This is caused by deposition of anti-GBM antibodies in lungs and kidneys, and it is manifested as rapidly progressive glomerulonephritis with pulmonary hemorrhage. So this is treated with repeated plasmapheresis along with steroids and immunosuppressants. We have ANCA-associated vasculitis. This primarily affects small arteries, and the cardinal finding is the presence of anti-neutrophil cytoplasmic antibodies. So these are antibodies directed against specific proteins in the granules of cytoplasm of neutrophils and lysosomal proteins in monocytes. So we have two major fluoroscopy patterns that can be recognized. We have a tissue cytoplasmic staining that is called C-ANCA, and we have a perinuclear or nuclear staining which is called P-ANCA. Coming to microscopic polyangiitis, this is systemic necrotizing vasculitis associated with glomerulonephritis and pulmonary involvement, but there is no granuloma formation noted in this. So this is the important feature. There is no granuloma formation here. Presenting features include purpuric rash, proteinuria, and hematuria, hemoptysis, venous involvement, and even arthritis. This is associated with presence of perinuclear pattern of staining, that is presence of P-ANCA, and also antibodies against myeloperoxidase are more specific. Treatment includes IV steroids, plasmapheresis, IV cyclophosphamide, and rituximab. Coming to granulomatosis with polyangiitis, previously called as Wegener's granulomatosis, most commonly involves renal and pulmonary system, but can involve any organ system. This is characterized by granuloma formation, and presenting features can involve purpuric rash, recurrent sinusitis, epistaxis, shortness of breath, hemoptysis from alveolar hemorrhage. And this is associated with the necrotizing glomerulonephritis that causes significant renal impairment. Patients with ERYTHEMATOSUS have C ANCA positive and a more specific is proteinase 3 specific staining. Coming to the diagnostic criteria, there are 6 features described. 3 out of 6 can make a diagnosis of GPA. That is abnormal urine analysis finding, that is presence of hematuria or significant proteinuria. Granulomatous information of biopsy when kidney biopsy is done, and when there is nasal sinus inflammation, sclerotic tracheal or endobronchial stenosis, or abnormal chest X-ray or a CT finding, and staining positive for PR3 ANCA or even C ANCA. So this is treated with IV steroids, plasmapheresis, IV cyclophosphamide, and rituximab. The third variety is eosinophilic granulomatosis with polyangiitis. This is previously called as Chagas syndrome. This has eosinophilic granulomatous vasculitis, and patients previously have a history of asthma, allergic rhinitis, or sinusitis. And this is characterized by non-fixed pulmonary infiltrate, and there is eosinophilic infiltration with multi-organ involvement. And we can also see neuropathy and cardiovascular disease. So here the ANCA positivity is seen in 40% of the patients, and it is typically, it is atypical or indeterminate pattern. Treated using IV steroids, plasmapheresis. Coming to vasculitis secondary to connective tissue disorders. First is Behçet's disease. This is a disorder characterized by triple symptom complex of recurrent off-the-cell vital ulcers and presence of uveitis. This is due to an autoimmune response triggered by exposure to an infectious agent, which has not been identified yet, and this is suspected actually. And this is predominantly seen in patients with ancestors along the Silk Road, that is Mediterranean to Southeast Asian countries. And this is a variable vessel vasculitis. This can affect small, medium, and large vessels. And patients are prone for developing unusual aneurysms, especially in the pulmonary arteries. And they're also prone for developing thrombosis of large veins, especially superior and inferior vena cava. Hepatic vein, mesenteric vein, renal vein, and even intracranial dural sinuses can also be involved, and thrombosis can happen. Venous thrombosis is more commonly seen than arterial involvement. Systemic immunosuppression with glucocorticoids and DMARDs and polycysteine thalidomide all have been used. Coming to SLE, nearly 30% of the patients with SLE show features of vasculitis, and most commonly small vessels of the skin are involved. And vessels, if medium vessels are involved, it can lead to mononeuritis multiplex. And if abdominal viscera and large vessel vasculitis are large vessels are involved, we see a similar pictures similar to Takayasu arteritis. And we should also keep in mind that APLS syndrome can also present in a similar way, and this should be considered as a differential diagnosis. Coming to rheumatoid vasculitis, vasculitis is seen in 10 to 15% of the patients, usually with a very aggressive form of the disease or who have a very high titer of rheumatoid factor. Patients may develop cutaneous ulcer, peripheral neuropathy, mesenteric vasculitis, and ARTERITIS. Then we have Pogon syndrome. This is an immune-mediated disorder characterized by interstitial keratitis, vestibular dysfunction, and sensory neural hearing loss. Medium vessels and large vessels can be involved. Then we have relapsing polychondritis and autoimmune disease with recurrent inflammation of cartilaginous tissues. Large vessel involvement with aorta leading to thoracic and abdominal aortic aneurysms may be noted. Then we have pseudoxanthoma elasticum. This is a inherited disease which causes early and diffuse arteriopathy in absence of traditional risk factors. Small and medium arteries are affected more commonly than the aorta. Then we have vasculitis mimics. So before making a diagnosis of vasculitis, these should be considered as a differential diagnosis. We have fibromuscular dysplasia. This usually affects medium arteries in women of childbearing age group, and usually carotid and renal artery will be involved. We have radiation arteritis. Patients typically give history of radiation to the field where the artery is involved, and usually they are present as stenosis. We have neurofibromatosis type 1, and we even have drug-induced vasculitis, any hypersensitivity reaction to any of the drugs, and drugs like beta blockers, ergot derivatives, and even intravenous drug abuse, such as cocaine, can also lead to vasculitis. And we have other conditions which can mimic vasculitis, such as endocarditis and infections. So coming to a approach to a patient with suspected vasculitis, first we need to exclude the mimic, and we need to examine for secondary causes. So to exclude the mimic, we can do blood cultures, echocardiogram. To rule out the viral infection, we can do hepatitis B and C screening and HIV screening. And to find the secondary causes, we can do anti-glomerular based antibodies, especially in children presenting with glomerulonephritis and pulmonary hemorrhage. And we can also do antiphospholipid antibodies. To assess the extent of vasculitis, we can do urine dissection microscopy, that is for assessing the glomerular involvement, and chest X-ray to see for pulmonary involvement. In some conditions, we might have to do a nerve conduction study and electromyography to rule out mononeuritis or polyneuritis. To confirm the diagnosis of vasculitis, for large vessel vasculitis and medium vessel vasculitis, where it is not possible to do a biopsy, we can go by angiogram findings. That is presence of stenosis or presence of visceral and renal artery bleeding or presence of atypical aneurysms. And for large vessel vasculitis such as giant cell arteritis, we can consider doing a biopsy of superficial temporal artery. For small vessel vasculitis, we can do either shave biopsy or a punch biopsy of segment of the skin involved. To identify the specific type of vasculitis, we need to see for anti-nucleoside cytoplasmic antibodies, cryoglobin, and complement levels, along with eosinophil counts or IgE levels. And we need to see for specific findings on biopsy, that is necrotizing granulomatous inflammation, presence of IgA deposits, and evidence of immune complex formation, or look for absence of the same. To just concise everything in one slide. So we have when we have large vessel vasculitis and it is granulomatous, and the patient is more than 50 years, it is likely to be a giant cell arteritis. If it is granulomatous arteritis in a patient of less than 50 years, it is likely to be triazoarteritis. When medium vessels are involved, if it is necrotizing without this mucocutaneous lymph node syndrome, that is polyarteritis nodosa. Necrotizing arteritis in presence of mucocutaneous lymph node syndrome is Kawasaki disease. So coming to small vessel vasculitis, we have immune complex in vessels. So we have in presence of cryoglobulins and hepatitis C infection, it is likely to be cryoglobin vasculitis. If it is IgA dominant, it is likely to be HS purpura. In presence of other rheumatoid disorders like SLE and rheumatoid arthritis, it is likely to be due to systemic vasculitis, that is SLE and rheumatoid vasculitis. In presence of other sources for immune complex, such as hypersensitivity reaction, cutaneous vasculitis will be noted. In paucity of vascular immunoglobulins, that is ANCA associated vasculitis, we have vasculitis with no granuloma formation and patient having no history of hypersensitivity or asthma, it is likely to be microscopic polyangiitis. If patient has granulomas and no history of asthma, it is likely to be granulomatosis with polyangiitis. If the patient already has history of asthma, shows eosinophilias and granuloma formation, it is Chagas syndrome. So that is it. Thank you and happy Sankranti to all.